me and looked after me while I was there. It was excellent. Um, so I mean, we can wait for another 5 or 10 minutes if we have more people joining. There's no rush to start.
Yeah, you can start. Hi, Alex. Hi. Yeah, you are muted.
Yeah, hello Manja sir. Hello Ravi.
Hi, hi.
Oh, is
Yeah,
that Alex from Colchester?
Yeah, Colchester. Yeah.
Oh, wonderful to see you.
Yeah,
After all these, how many couple of years at least now, I think, isn't it?
that's right. Yeah, down the road, but we have never met. Yeah.
Exactly. I have come to your place twice, to the Oaks, but
To the Oaks. Yeah, fine. Okay, to make some pocket money. Yeah.
yeah. No, that's because I don't know, for one reason or another, you guys haven't been able to cover the surgeons that
Yeah,
I work.
that's right. I mean, that's gone up a bit more because we're doing a lot of COVID-related work there now. So,
Okay.
the syndicate is just not able to cover now.
Is it? Oh, right. Yes.
okay. Yeah, we have quite a few people here. Anita madam is also there. Lot of, yeah, now 40 people are there. You can slowly, I think you can start.
Okay.
So,
Right.
yeah.
So, just a brief introduction before I start the video. So this, since this is all very, quickly put together, so we haven't had much time to really organize this properly. So Manjunath told me, look, we'll have this meeting and you can show some videos of what you've done. And just that weekend, that last Friday, I was doing a revision knee, and I thought I'll just get a video of what blocks I do for a revision knee. And that is, so this video is about 8 minutes long, and I actually talk along with the video, so things will become clear as they do. So that's what it is. So I'll just switch the video on now and share screen. You're taking me, and this is it. Mm-hmm. Is that clear now? An introduction. I'm doing a case today
Yes,
for
it is
a
clear.
gentleman who's having his revision knee done. Because it's a revision knee, the anesthetic plan is to do a femoral nerve block, an adductor canal block, and a popliteal plexus infiltration, followed by a total intravenous anesthetic technique. And hopefully, this will provide very good intra-op analgesia and post-op analgesia. On top of that, I will give them at the end some intravenous fentanyl, and during the operation, paracetamol, some non-steroidal, and some IV magnesium sulfate, and sub-anesthetic dose of ketamine. So all of this put together should keep the pain at bay. So this is nothing new. I've done this. I'm sure you guys have seen this quite a bit. It's a femoral nerve block. Do you want to see, Stuart? Have you seen femoral nerve?
Yeah, I have.
So that's the femoral artery, and that's the femoral nerve there. Mm-hmm. You can see very nicely. So sharp scratch coming up. This is an out of plane technique, and I'm using 1% lignocaine to do a femoral nerve block. It's the correct side. You're happy with the side, aren't you?
Yes.
Yes. So there's a local anesthetic being infiltrated, and it's lifting the nerve up very nicely. I'm just going to move the needle a bit more medially. You can feel it. There's a nerve being pushed down. When the local anesthetic surrounds the nerve, it becomes more obvious. There's a needle tip there. Beautiful nerve.
Well,
You okay? What is it?
pain.
Where?
Where you doing it?
Okay. That's the pressure of the injection. Nothing going down your knee or anything, is it?
No.
No. Okay, that's the femoral nerve done. Do you mind holding that?
Yeah.
You want to put some jelly there?
Yeah.
The next injection is going to be an adductor canal block. So that I'm using 0.375% opioid. You want to come around here? So I can just point it out to them. So that's the sartorius muscle. That's the femoral vein. That's the femoral artery. That muscle there is the vastus medialis, and that muscle there is the adductor muscles. And this is medial, and that's lateral. So in this territory, that's the adductor canal. The femoral artery is inside, and the saphenous nerve is lurking somewhere in that area. So I'm going to go lateral to the femoral artery. Sharp crutch. Going to go lateral to the femoral artery, and you'll see this is an in-plane technique. There's my needle coming into view. And it's entering the adductor canal there, that's it. And you see the local anesthetic. There it is. It's filling up the canal. So all this is being done while the patient is awake. So like I've said before, I think I do all my blocks awake. So, it's as safe as possible. And the last injection is going to be the popliteal plexus injection, popliteal plexus infiltration. So you want to come here. That's your saphenous nerve there, and that's the infiltrated adductor canal, the local anesthetic. What I'm going to do is just follow the femoral artery down. This one can here as well. So I'm just moving it down the thigh, and until can you switch the light off, please? Until the femoral artery starts to disappear. So you can see that's the femoral artery there, nicely bouncing away. And then when I come down, it starts to disappear. There you can see it still. And somewhere there it's sort of becoming almost invisible. So I want to go back to where it's slightly visible. There's a blood vessel, so that's not a good place. So I'm just going to be there now. Blood vessel on top there, isn't it? Right, okay, that's better. So you've lost the blood vessel vein, I think that was on top. Now I'm going to go just above the femoral artery, sharp scratch again. So you can see the needle coming in. And it's just placed above the femoral artery. And you see the femoral artery being pushed down. Good. That's better. So you see the femoral artery is being pushed down. So you're placing the local anesthetic on top of the femoral artery. So once this is just very close to the adductor hiatus, through which the femoral artery disappears into the popliteal fossa to become the popliteal artery. And so dye studies have shown that the local anesthetic will travel with the femoral artery through the adductor hiatus into the popliteal fossa and distribute itself behind the posterior capsule of the knee joint, and therefore providing sensory analgesia to the posterior capsule of the knee joint. That's it. Thanks very much.
So,
Okay. Yeah, I would like our PGs as well as the other anesthetists to ask question to Ravi, because we have a expert here who has done the blocks. And I would like to, first, I would like to tell the PGs, please notice how you have to keep talking to the patient, keep informing the patient. That is very, very important when you do a regional anesthesia, because in our areas, many times we have one small advantage. Whatever we talk in English, quite a few of our patients may not understand. But it is different when you go to, say, England or any other country where people normally speak in English. So you can't be talking something which is irrelevant, which is not nice to the patient. See, the communication should always be there. It should be a continuous communication with the patient. Also, it helps in monitoring the patient. Some of the old patients, you never know whether there is any problem. So you should be keep communicating with them. And that is a very important fact. I think you should notice how he was talking to the patient at every step, explaining to him every step. And also whenever needle pass is there, all that is very important. We should never ignore this particular fact. So that is one thing I would like to tell our all the PGs as well as others. And yeah, back to anybody has got any question, please raise your hand.
Ravi, just one clarification. The last injection that you did, I am assuming that would have the same effect as an IPAC block, isn't it?
correct. Yes, yes.
Yeah. Okay. Fine. Okay. Yeah.
Yeah, I was also having some kind of similar doubt. IPAC, do you use IPAC block, especially
So-
the posterior part when you go?
Yeah, I used to do IPAC back in, I think it was 2014 or something like that. I met Sanjay Sinha in New York, and he presented, and it was really, really impressive. So I came back and I used to do that. The problem, I don't know, maybe it was self-inflicted, I'm not sure, but because the needle was being placed very close to the posterior capsule of the knee, I made the whole injection of IPAC aseptic. So I used to scrub up like I would for an epidural or a central line. I would drape the area. I would drop the local anesthetic, like an epidural or a spinal, complete asepsis just for that injection. And unfortunately, it was adding time to my procedure. So if I had 4 joints, my time at the end of the day would be, if all 4 joints, if I did the same thing, it was adding a lot of time and the lists were overrunning. So unfortunately, because of that, I decided to stop doing that. And just probably a couple of years ago, there's a chap called Jens Boglam, who's a Danish anesthetist, who's also very well known among regional anesthesia circles. He presented a talk in one of the ELSORA meetings, which I saw on YouTube. And he showed this technique, which is not, the needle is nowhere near the posterior capsule of the knee, but is essentially producing the same effect. And therefore, for me, it was beneficial because I didn't have to then go into strict asepsis. The injection is far away from the needle, so I'm not introducing by any chance, any infection next to the knee joint. So in my mind, for me, IPAC was, but I see now this morning when I checked USRA website, I noticed that the IPAC injection is being done exactly like how I did my Popeye injection. It's not strictly aseptic. It is a non-touch technique. So I don't know. Maybe I was self-inflicting, and doing all the aseptic technique. But essentially, it's the same injection.
Yeah, actually, I had not seen saphenous plexus block before. Actually, this is the first time I am watching it also.
The adductor canal block, you mean?
No, adductor canal I have seen, but the next one,
the popliteal plexus infiltration.
popliteal plexus. Yeah, sorry,
Yeah.
popliteal plexus block.
Yes.
First time I also saw that. Yeah, IPAC I have seen, and probably a couple of times I have done. But yeah, I think there is a nice to know this alternative also. We are not going just behind the knee. We are going little above. Yeah.
Correct. Yes.
Okay. Any other questions? We have quite a good number of people in the group. Yes. Anybody has got any other question? Please unmute yourself and you can ask the expert. They can raise their hand. Otherwise, Ravi can tell us something more about, say, knee surgeries. What else? I wanted to know in case of a total knee, many times, especially our surgeon, you know him, Sharath. He was there last time's inauguration also. He is very concerned about the weakness of the knee also. I think adductor canal, as they go down, the weakness comes down. I mean, very minimal. So what is your experience and what is your opinion?
Actually, I have a video on my phone. I don't know if I haven't, and I've next morning. So this surgery, when I really started doing this, maybe 6-7 years ago, I used to go. I went back on Saturday morning to see this lady, and this was 8 o'clock, and I went to her bed, and she was missing. I thought, my God! And this lady was somebody who had COPD, and she was a chronic pain patient on lots and lots of opiates. So I thought, my God, has he had trouble overnight and gone off to ICU or something? But she had actually gone to the toilet, and you could see her walking. And the physiotherapist said, this lady's walk is proper walking, heel toe walking is what they call it. So there was no sign of any weakness at all. And the other thing is, adductor canal block has been performed in, I think, about 8 or 9 volunteers. So this was a study published on volunteers, and they measured the strength weakness in the quadriceps muscles. And they do, I forget what the test is called. It is a test where they ask the volunteers to get up and go. And even though, the only motor nerve in the adductor canal is nerve to vastus medialis. And that has to be blocked, actually, because that does provide articular fibers to the knee joint, which seem to be quite important. So even if that nerve is blocked, the reduction in quad strength is only about 10%. And therefore, they are still able to carry out physiotherapy. They are still able to walk. So there shouldn't be any, clinically relevant muscle weakness after an adductor canal block.
Ravi, one clarification with regard to, as you said, very important to block the nerve to vastus medialis.
Yes.
To achieve that purpose, where would be the optimal site of performing the adductor canal block?
Right. So again, there's a lot of debate going on, and this Jens Boglum guy with his team of people, they have dissected cadavers and things like that, and they say you have to do a femoral triangle block to catch the nerve to vastus medialis, because if you go into the actual adductor canal, then it seems you lose the nerve. It doesn't travel within the adductor canal. Obviously, I'm not an anatomist. So what I try and do is I go, really very high. So his description of femoral triangle, I think, is a midpoint between the anterior superior iliac spine and the medial aspect of the femoral condyle. And so that is where the apex of the femoral triangle is, according to him. So that is what I try and aim for. I try and go as high as possible in the adductor canal. If you are in the proper adductor canal, if I am not wrong, the femoral artery is in the middle of the sartorius, and you can see the femoral artery, sort of making a sort of impression on the belly of the sartorius. So what I do is I just go right up further where the femoral artery is on the medial side of the sartorius, and somewhere there is I try and put my local anesthetic. I'm not sure if that is the apex of the femoral triangle or not, but that is what I've been doing. And my, the thing about this, all these nerve blocks, they really are, you cannot achieve pain-free duration. Some patients are really pain-free, some others are not. You just have to, you are trying to achieve the best of all worlds. You give them lots of oral analgesics and, give these blocks and try and see how best you can relieve their pain.
Ravi, one intervention that I found is very useful as part of the multimodal approach for knee replacements.
Yeah.
In addition to blocks plus analgesics, is the use of a cryocuff. So the cryocuff is basically, I guess you can call it a blood pressure cuff,
Yes.
through which ice cold saline is circulated.
Yes.
So it basically works on the principle of cryoanalgesia. It works excellently well. I mean, I've seen patients mobilizing with that very comfortably.
Yes. I've tried that. Obviously there's this resource issue. I've told my
Yeah.
surgeon we need to get this, because there's also this quadriceps. I think the quadriceps mechanism gets impaired. There's a dysfunction because of the tourniquet, that we use during the intra-op, that really disrupts the quads mechanism. And so if you do have weakness, it's really nothing to do with our blocks. It's because the quads mechanism has been caused problems because of the tourniquet and the surgery itself. So, and this, like you said, the cryo analgesia seems to be of really benefit to these people.
Yeah, I've heard of some surgeons operating without the tourniquet also.
Yes.
Do you have such surgeons, such experiences?
There's a private hospital near where I work, and there are two guys who do, the knee replacement without tourniquet. I haven't worked with them, so I haven't actually looked at how it works.
Yeah. Madhusudan says they do. Madhusudan is a professor from Mangalore KMC. So he has also joined the meeting. He says they do without tourniquet also, the knees replacement. Yeah, but in Manipal, Sharath is the surgeon who operates. Of course, he is lightning fast, you all know.
So how long is the skin to skin, Manjunath?
Sorry?
Skin to skin is how long?
That is the problem, because skin to skin, of course, it will take 1 hour. Problem is his time is maybe 10 or 15 minutes, but rest of the things will be done by others. So that will take a lot of time. So ultimately, yeah, for us, anesthesia time, it will be long, but his time and tourniquet time, it will be much shorter, very, very, very quick. It is so quick that when we used to ask them to give infiltration for the posterior part of the capsule mainly, and the assistants were finding it very difficult, because by the time they take the syringe with the local anesthetic, Sharath would have finished this part. So there is no time. So that's how it was.
I think Sharath sir is getting better with age, I think.
Yeah, he is. Yes. So that is how it is. He always uses tourniquet in our place. But as I have told already, because the time is very short, tourniquet inflated time, maybe something like 20-25 minutes, all that. So it doesn't really matter much, I would think. And he gets the best kind of blood-free kind of field, which he likes. Otherwise, it will start probably irritating him also once in a while. So he gets a good field. At the same time, he does it very quick. That's how it is. Yeah. Anyone else want to ask any question or some clarification? Yeah. Somebody.
Ravi, what was the what is the volume and concentration of the local anesthetic you inject into each of these places?
Okay, yes. So, you might wonder why I'm doing the, femoral block obviously was the quintessential block we did in the past for knee replacements, but then the quads paralysis, started causing problems, and therefore we went away from femoral nerve blocks. But what I don't use the femoral nerve blocks for primary knee replacements because my anesthetic technique there is a spinal anesthetic. So I just do the adductor canal block and the pop eye block for a primary knee replacement surgery. When they're having a revision knee, because the duration of surgery is really undefined, so I never give them a spinal anesthetic. I just use a general anesthetic. And in this case, or in most cases, I use total intravenous anesthesia. So what I thought was, why not use the femoral block for intra-op anesthesia and minimize my anesthetic requirement intra-op? So therefore, I started doing short-acting local anesthetic femoral nerve blocks like 1% lignocaine or even 1% prilocaine, whichever is available. So that's what I do. I use about 15 mils, 10 to 15 mils of local anesthetic to do my femoral nerve block. So by the time the surgery is finished, the femoral block is also worn off, and therefore there's no reason for them to have prolonged quads paralysis and preventing them from doing physio. For instance, this patient who had his surgery on Friday, revision knee replacement, single stage, on Monday he went home. So it's absolutely brilliant. And obviously the adductor canal block, I put in 10 mils of 0.375% ropivacaine, and same goes for the Popeye block. I use 10 mils of 0.375% ropivacaine. On top of this, I get the surgeon to infiltrate as well. Now, my surgeon is not, he's quite afraid to go in, to inject the posterior capsule of the knee, just in case the needle goes further and goes into the popliteal vessels or and even nerves. So he doesn't go anywhere near the posterior capsule. He just infiltrates the medial and the lateral aspects of the knee joint and also the anterior aspect of the skin incision. So he uses about 50 mils of 1% ropivacaine. So in total, that's about 175 milligrams of ropivacaine and to 200 milligrams of lignocaine. So that is the mixture. If I'm doing a revision knee, that is what I use.
May I?
Yes,
Yes, please.
Madhu.
Yeah.
Go ahead.
That's nice, Ravi. Basically, I used to do femoral nerve block for most of the knees. But then, as I said, the physiotherapist, when he starts mobilizing the patient by evening, the quads would be weak. And then I had to start diluting the local anesthetics and start some additives. Would you use any additives?
I'm not a fan of additives.
Okay, me too. But subarachnoid space, I don't. But for the blocks, I do use.
What do you use?
I usually use dexmedetomidine, but
Sorry, somebody is.
Roshan is unmuted.
Yeah, Roshan.
Yeah, my issue is Ravi. We start. I mean, obviously, the way forward is adductor canal block. But the problem is when the dissection is too much on the lateral aspect, the patient will still have pain.
Yes.
Post-operatively. That is when I go back to femoral nerve block. Do you suggest anything else other than going back to the femoral nerve block rather than, can we do something else with the adductor canal block?
Actually, the surgeon who I work with, so all this anxiety about getting the people the next day, getting them to do physio, get out of the bed quickly. He says really that hasn't shown to bring about an impact on the final outcome in large numbers of patients. So even he is not really convinced that all of our anxiety to, prevent quartz paralysis and get them to walk the same day even is really called for. And the question is, and actually there are even some articles that talk about it. So the question we need to answer is really, which is more important, providing really good analgesia and making sure that the knee moves. It doesn't have to be an active movement. We can have a continuous passive motion. So we get a CPM machine and the patient can be in their bed and this machine, flexes and extends the knee. And we provide very good analgesia that way. Or is it better for the patient to be doing the physio themselves, being out of the bed? Now, that is a really question for maybe the surgeons, and to look at long-term outcomes, if all these things that we are doing are actually making a difference to the outcomes from the knee replacement surgery. But because of this limitation, we are really stuck with trying to provide just sensory analgesia and getting the patient to get out of the bed and do the physiotherapy. So as long as that is the requirement, unfortunately, we haven't got anything more to do really. And also the surgeons have themselves accepted that the outcomes of knee replacements are really limited by the pain. They have got as far as they can, as far as the prostheses are concerned. There is no more, for them to do with that design of the prosthesis. They really looks like they've reached the limit of what they can offer.
Yeah.
So it's the pain which is limiting the outcomes of this operation.
Yeah, when you talk about the enhanced recovery, basically it has come to us from the Western world.
Correct. Yes.
The enhanced recovery, and the orthopedic surgeons, they sincerely believe that they have to mobilize the patients as early as possible to have better outcomes. What we try is, one sec. What we try is, as Alex said, multimodal.
Yes.
We start off as soon as the patient says patient has a VAS of about say 4. We start paracetamol. We go ahead with the toricoxib. They're all actually not just PRN. They are scheduled dosings. Yeah, they do get, and they can still walk around. I think it helps the enhanced recovery. But anyways, you discharge the patient on the 3rd day, but we can't. In India, the physiotherapist cannot go home and provide the therapy. Therefore, they will be stuck in the hospital for a week or 8 days.
Oh, that's quite long.
7 days is actually, when you talk about the packages, I don't know whether you know about the packages. We provide packages for 7 days hospitalization.
Right.
And they pay a fixed amount to stay in the hospital for 7 days, including the surgery and the rehab. That's why I really wonder whether the enhanced recovery really works there. But early mobilization obviously will bring down the complications too. Therefore, no, then multimodal is the way forward. Adductor canal and multimodal.
Absolutely.
Yeah. Thank you so much. Thank you.
Madhu sir, if I can just add one point. What I have found with knee replacements is the unbearable excruciating pain is basically from the posterior compartment. If that aspect is covered with an IPAC block, and if you have come, I mean, I don't think intrathecal prilocaine is available in India, but we are with some of our quicker surgeons, we are starting to do fairly straightforward unicompartmental knees with prilocaine spinals, and hoping to get them mobilizing the same day evening itself. With an IPAC block and an adductor canal block, and that seems to work. And certainly centers that are doing larger volume cases than us, especially with prilocaine, they are achieving. In fact, they are able to achieve same day discharge. Especially for the cases of 1st or 2nd on the list, they are able to achieve same day discharge.
What do you use for IPAC, Alex?
Sir, it's a volume block, as Ravi was saying. So if it permits, I will use up to 30 of 0.375.
Okay. Sure. Thank you.
And put 10 for the adductor canal.
Okay.
Yeah, just Alex or Ravi, just a question from my side. These blocks, how long, say you are planning to discharge them, say next day or same day or something like that, how long this will give pain relief for them? And what is your advice for other additives? Like, what I mean by additives is taking oral or something like that? What are the other things you advise in these cases for this patient?
So my standard practice, even for upper limb blocks, lower limb blocks, is I make this a point to tell them is that please start taking the multimodal oral analgesics before the block wears off. That is so important, because even if you were to draw a diagram of serum levels, if you don't take it before, that level will not build up by the time the block wears off. I guess the purpose of the block is to take care of that excruciating immediate post-op pain. You may get, I don't know, 8 hours, maybe 10 hours, I guess, maximum.
Yeah.
But I think it will also help to prevent that excruciating buildup of psychological issues as well. Or can I walk with this pain? That will be taken away by the block. But obviously it won't provide long-lasting post-op pain. But taking the oral analgesics on a regular basis, 8 hourly or 6 hourly, before the block wears off, I think that is the crucial point to tell the patients.
Yeah. Yes. So Manjuna, I mean, like Alex says, ideally what we should be doing is giving them oral analgesics before operation. So they should be getting their paracetamol and a non-steroidal before you start the anesthetic even on the ward. And so it's already in the patient's system while the surgery is going on. And post-op, you prescribe regular paracetamol, non-steroidal, and a slow release opioid, like we have oxycodone slow release here. So that is given regularly. It's not PRN, it's a time-based, so that the patients, like Alex was saying, you just don't wait for the levels to change, just keep giving it. And then on the as required side, you prescribe either Oromorph or oxycodones, quick release. And so that is for rescue analgesia. And this is the regimen we have here. Intro, even if they're having a spinal anesthetic, it will be ideal if we can give them something like 0.25 milligram per kilo of ketamine, and also dexamethasone is shown to be useful intravenously to as an adjuvant to analgesia. And I've recently started using IV magnesium sulfate, about 50 milligram per kilo bolus slowly, and that seems to be quite, I don't know, there are reports talking about its usefulness. And all these things are, they work together. None of them on their own will be analgesics, but when you're using everything else, these things, they sort of are quite useful. So this chap who had the revision knee replacement, all I gave him was 100 mics of fentanyl, and he didn't get any more analgesia in the recovery, and he went back to the ward without having received any more analgesia. But that's not always the case. Some patients, obviously, they vary. Some of them get another 100 or 200 mics of fentanyl while they are in the recovery, because the pain is different, the way the innervation of the knee is different. So we just have to work out what is best for that given patient.
Ravi, can I ask, do you prescribe preoperative and postoperative gabapentin?
No, I used to.
Yeah.
But there was a review, meta-analysis of gabapentinoids published maybe a couple of years ago, and what they found was really it wasn't adding a lot to the analgesia.
Yeah.
It was causing a lot of nausea and vomiting. Oh no, it was reducing nausea and vomiting, and actually.
But sedation was a problem, wasn't it?
Correct. Yes. So once I saw that, I just stopped. And also there's the issue of falls as well, post-operative. So I stopped using, but some of the orthopedic surgeons have latched on to that, and they want, we want pregabalin. I don't stop prescribe anymore. I've stopped that.
Yeah, how often you do, say, knee replacements with general anesthesia? Because our side, almost 100% under spine. You can say, unless there is a real contraindication. What is the stat like in your areas?
It's exactly what you described, Manjana. Our first go-to anesthetic technique is spinal anesthesia. But as you know, the arthritis that you see in the knee or the hip is also seen in their
Fine.
backs as well.
Right.
So you can have, you can have done hundreds of thousands of spinals, but there will be times when your spinal, you cannot get into the space. Sometimes you might get into the space, your block won't be adequate. So there are, innumerable times that you have to give them general anesthesia, so, and if you have done blocks, really, uh, they wake up very quickly because
Yes.
the anesthetic requirement comes down tremendously.
Yes.
I don't know, when I was growing up as an anesthetist, we didn't have any blocks. We used to give them tons and tons of morphine. Their blood pressure used to shoot up, shoot down, it was all over the place. And these patients who are 80, 85 years old won't wake up, won't breathe. And,
Correct.
all those problems are gone because, our blocks really make a tremendous difference to the GA as well. So it doesn't make a difference.
Anybody has got any other questions?
I mean, when I started in the UK, standard practice for knee replacements was a femorosciatic block.
Correct.
That has changed a lot with the enhanced recovery coming in.
Yes, obviously I've been in the UK since '94. So those days, so we used to put the patient on their side and send them off to sleep, stick an LMA in, and then once they are asleep, you go on their side and stick a spinal in, and then put them on their back. That was the standard technique because those days nobody wanted to be awake. Every patient wanted to be asleep. Only patients who are awake for an operation were cesarean sections. That's it. So that was, and we used to do epidurals asleep as well. Even thoracic epidurals, we used to, do them asleep. So they were completely different days back then.
I'll just see whether anybody has commented anything. No, anybody want to ask any question? Because Ravi has taken special kind of, he even applied a leave for half a day and he is sitting. Alex, how are you free now? You are post duty?
Sir, I was on nights last night. So,
oh, okay. No, because initially we thought it may be a little tough for Ravi. It's in the afternoon, but then he took a half day off, and then he is with us. So he has got a lot of time also. Anybody has got any other questions? We thought it is a very short and quick, but it is we are almost 40. In fact, we were 1 hour in this meeting, and at least from starting time, it is almost 45 minutes. That is very nice because I like the discussion rather than any one single lecture or a topic because you can clear a lot of doubts. But PGs are still little hesitant to question or clear their doubts, I would say. So I think they should develop that habit. Anyone else has got any question? Otherwise, I think we can relieve Ravi and from Tirth has got one question. Yes. What is it? Yeah, Tirth, go ahead. Unmute yourself and ask the question.
So do you use epidurals in your practice and for knee replacements?
So shall I answer?
Yes, please.
Okay, so in the late 90s, when I had just become a consultant back in '99, that was we used to do a lot of epidurals for knee replacements. But obviously, the problems of epidurals. They can cause hypotension, urinary retention, and all these mobility issues. And then what happened was we started doing these blocks called as 3-in-1 blocks, which are essentially a large volume femoral nerve block. And to my surprise, my pain nurse in the hospital came up to me and said, Ravi, if I had a knee replacement, I would rather have your 3-in-1 than an epidural, which I found very hard to describe. But when she went around the patients, that is what she realized, that the nerve blocks were performing better than epidurals. So really, epidural is long consigned to history for primary knee replacements. Obviously, you will have some patients who are chronic pain, who are, they're on 400, 500 milligrams of equivalent of morphine, and they have come in for a primary knee replacement. Any block that you do will not be useful for them. You have to have for 2 or 3 days, provide regional anesthesia. So in that patient group, either a continuous femoral nerve block or an epidural, whichever you're comfortable with, is really indicated in that group, because the main bulk of the patient's pain has got to be relieved by regional anesthesia. Any opioid that you give them will not be of any use to them, because they're already on, super maximum dose of these things, and you cannot relieve the analgesia. So yes, that is probably only place where you have, epidurals coming in. Otherwise, in everyday practice, spinals and nerve blocks are the only, mainstay of anesthesia as far as I'm concerned.
Tushar is asking one question. Tushar, go ahead.
But for primary knee arthroplasties, what nerve blocks do you use regularly there? Because we do it under spinal alone, and we do not use any nerve blocks in our practice here.
Right. I'm sure maybe you did not, focus on what I was saying. So for primary knee replacements, the anesthetic technique is a spinal, like you just said, like what you do. But as you know, spinal anesthesia wears off in 6 hours at best. And yes, you can add diamorphine here, maybe morphine there, but those things are not, they may prolong analgesia to some extent, but they're really not satisfactory. And there are also lots of drawbacks with adding opiates to spinals. So you have to prolong analgesia, and that is where the role of adductor canal block and either the IPAC block or Popeye block. So the combination of adductor canal block and infiltration analgesia, some form or the other, either local infiltration analgesia by the surgeon, or you're doing the posterior capsule block and LIA by the surgeon. You have to have this. Even adductor canal block on its own, initially we thought, when it was first described, that it's that's the be all and end all of analgesia. But there were patients who were benefited by it, but there were also patients who are not really achieving a great benefit by it. And therefore, the combination of adductor canal block with local infiltration analgesia is what is recommended for primary knee replacement. So spinal anesthesia on its own is not good enough. It'll wear off, and we are back to square one as far as pain is concerned.
Ravi, one question.
Yes.
Going forward, if you get access to liposomal bupivacaine, would you use that for your blocks?
I think so, yeah. It makes sense, doesn't it? And it's been, for shoulder interscalene blocks, it's been approved by the FDA.
By FDA, yeah, that's right. Yeah.
But 2019, last year, I was in San Francisco for the ASA meeting, and there are lots of skeptics about this liposomal bupivacaine. It's not universally accepted there even. So unless there are lots and lots of articles coming out and saying that it is really, really useful, obviously we are not in research centers, we don't perform studies ourselves. So unless all these gurus come and tell us, look, this is good or not good, in theory, it does sound very useful.
Yeah, there are a lot of messages. Actually, I'm getting like WhatsApp message and things like that, saying that the discussion is very useful and people are finding it, the interactive discussion is the best way to know the subject. And so I'm getting, but nobody is asking question, but I'm getting the messages saying that this is the best way to interact and find out the solution for their questions.
If I can just add one point. I was mentioning earlier about the advice I give to patients. One point of advice that I give for upper limb blocks is specifically to be careful about handling hot substances. So, making coffee, tea, whatever, just completely be aware of that, the fact that that arm is insensate, and you may get silent burns without knowing that you have actually burnt yourself. So I guess that's relevant for the lower limb as well.
Yes,
Correct.
yes,
Correct. Ishwar want to ask some question. Ishwar, go ahead. Ishwar is the one who was who gave vote of thanks last time also. I think this time we'll make him give vote of thanks again.
No, not at all. Good evening, Ravi sir, and good evening, Alex sir. Nice seeing you.
Hello, Ishwar. Hello, Ishwar.
Yeah, sir. My question is this IPAC block which you have described for.
Hey, Ishwar, open your camera also, man. Video camera. Let us see you also. I mean, if you are.
Sorry.
If
No,
you are
sir.
presentable,
Yes,
it's okay. Otherwise, if you are not presentable, it's okay.
Presentable, sir. Presentable. I just got from the ICU. Sorry.
Okay.
Sir, my question is for the regarding the IPAC block. So you suppose at the end of the surgeries, when do you administer the IPAC, sir?
It's all done at the very start.
Beginning.
So you give us spinal anesthesia and then you give the IPAC block, if I'm right.
No, Ishwar, I would do it the other way around. I would do any nerve block before you numb the legs.
Right, sir.
Okay,
right.
So that any paresthesia you can appreciate.
Right. Okay, paresthesia you could appreciate. Yeah, I just wanted to know the timing, sir, as to. So you use a curvilinear probe, if I'm right, for the IPAC.
Yes.
And preferably in the supine position with the knee flexed. Is what you would
prefer? Sort of hip abducted and knee flexed. Yeah, correct. Yeah.
Knee flexed. And you administer the IPAC, followed by which you give the spinal anesthesia and then monitor. Right, sir. I just wanted to know the timing, sir. Thank you.
Yes.
Thank you.
Yes.
Okay. Anyone else?
So, how does a patient tolerate so many injections? What do you give before that?
I mean, my video is, the evidence for it. He hasn't had any sedative. I haven't given him any sedation, nothing.
Okay.
I didn't even, if they are younger patients, so I do, the surgeon that I work with, he also does anterior cruciate ligament repairs. And for them, I use a TIVA anesthetic, and they are generally, very sporty people in their 20s or, maybe early 30s even, and they are a bit more anxious about having injections awake. So because I'm using TIVA, I start the remifentanil infusion at about 3 nanograms or so they can become nice and comfortable, and I can do the injection like that. But this chap, he was probably 60-year-old. A lot of the revision knees and primary knees are in that age group, 60, 70, 80. And, they're really not fussed about having the injections awake. And the needle is only a 21 gauge needle. So it's not, it's not even 20 gauge. So the discomfort really, I asked them afterwards, was it too bad? And a lot of them say it doesn't bother them that much.
Ravi, again, just a question about your personal practice. I know we are discussing about knee replacements, but what would be your choice of block for arthroscopic repair?
Arthroscopic repair, ACL.
ACL, yeah, ACL.
I do I do adductor canal blocks. I do the same block even for that.
Yeah, fine.
And I get the surgeon to infiltrate as well.
Okay. Any other question? Anybody wants to ask any doubts?
Just one more, sir. Sorry.
Yes, sure. Go ahead.
Your
you are not audible, Ishwar. I could hear only up to your. Yeah.
Lost connection.
But his speaker view, I think he is still on. That means he's.
Yeah. Now.
Yeah. Go ahead.
Sorry, sir. Yeah, I had a network issue. So your tips and tricks for a subgluteal sciatic.
Oh. Subgluteal sciatic is a difficult block, really. And actually, I used to do that quite a bit for my knee replacement surgery about 5 years ago, 6 years ago. My technique was that femoral block and gluteal, subgluteal sciatic nerve blocks. So if you have an obese patient, it's really, really difficult, and sometimes you have to give up and you not do it. It's just, getting your landmarks right, feeling your ischial tuberosity, greater trochanter, and, scanning and also changing the angle of your probe sometimes makes a difference. Besides that, and also, in elderly patients who are in their 80s and who haven't got a lot of obesity, haven't got a lot of muscle, even in them, the sciatic nerve, becomes very, very difficult to see. So the subgluteal sciatic nerve, because it is, there are not many big vessels near it, and because it is squashed between the quadratus femoris and the gluteus maximus, it's very difficult to visualize. So it is a technically challenging block, I would say.
Exactly, Ravi. Ishwar, if I can just add on to that, the big challenge with blocking the sciatic nerve is that from our point of view, the sciatic nerve does not run parallel to the skin throughout its entire course. So because of that, the anisotropy of the nerve is not uniform throughout its length. So from that point of view, I would say the best approach or the easiest approach for the sciatic is probably the popliteal sciatic approach.
Yeah.
It's more comfortable for the patient, and ergonomically also, I feel the sciatic approach, the popliteal sciatic approach is probably the easiest. The nerve is you can actually see the nerve dividing into the common peroneal and tibial, and just block it proximal to that. It's actually, I would just go for that approach, to be honest.
Yeah.
Thank you, sir. Thank you, sir.
Okay, it's almost an hour now. Thank you very much, Ravi, and thank you, Alex, for joining and helping us. It was really, both of them are, just to tell our PGs, both of them are adjunct faculty. They would have, probably I would have invited them over during our up gap, all that. We would have had a lot of this kind of interaction, and of course, the parties, which we can't have online. So all that we could have done, but then, but for this. Yeah, I heard somebody was talking in the background. Anybody has got any other thing to ask?
No, when you talked about the parties, I thought I can come down. No issues.
No, we can come up also. We
If
can
I-
come to Mangalore also. No problem.
Yeah, please do come.
Yes.
Please do come. Be my guest.
Thank you, Madhu. Thank you, Madhu, for joining. Yeah.
No, it was really nice, Ravi and Alex. I think we learned a lot.
Oh,
Yeah.
thank you.
Thank you so much.
Though the rhyme Ravi and Alex go together, this is a different Alex, not the original Alex.
Okay.
Okay.
Sure.
Okay. Thank you very much, Ravi and Alex also. And we'll sometimes like this, we'll have some kind of interactions. I'll keep in touch. Thank you. Thank you very much.
Thank you.
Thank you, sir.
Bye.
Thank you. Nice meeting you, Ravi. Thank you.
Same here. Yes. Thanks.
Thanks,
Bye-bye.
Manju. Thanks.
Thank you to everybody.
Thanks.
Right.
Nice seeing you, Ravi.
Oh.
and Alex.
How are you keeping?
I'm fine. Thank you. How are you? You look good.
Well,
You
thank you too. Yeah. Oh.